Kia ora tātou, everybody. Bruce Harrell's my name, and I'm the director of the Goodfellow Unit. It's my pleasure tonight to introduce our two speakers who are going to be talking about screening for bowel cancer. Our main speaker tonight is Adele Melton. She's a New Zealand-trained gastroenterologist who spent time in Oxford. She's currently working as a consultant gastroenterologist at Middlemore, and she's the lead for the bowel screening program. And there's Ian Bissett, who's well known. He's been on broadcasting with us many times, professor of surgery in the Department of Surgery at Auckland University, and he's a colorectal surgeon with a co-director of the nutrition support team, Auckland City Hospital. So Adele, over to you.
Thanks so much. That's a wonderful introduction. I'm really delighted to be here tonight talking to you about a topic that I'm really passionate about, and one that's of huge importance here in New Zealand. Bowel cancer. So as Bruce mentioned, I work at the McMurray Centre and also at Middlemore Hospital. So what I was going to cover tonight was, first of all, just an overview of bowel cancer, and then specifically hone in on polyps, talk about the National Bowel Screening Program, and then special focus on early onset colorectal cancers. We can go through risk factors, and then I've got a few cases to present, and then at the end we'll have a open forum for questions, and then a panel discussion with Ian, which will be great. So bowel cancer. 3,000 New Zealanders are diagnosed every year. So I'm sure everybody out there will either have loved ones or family members or colleagues at work or people they know that have been diagnosed. Around 1,200 die from it each year. It's the second leading cause of cancer death in New Zealand, second only to lung cancer. Can affect people of all ages. So despite what we were kind of honed in at med school that it affects older people, it can affect younger people as well. About 350 young New Zealanders are diagnosed each year, so young is less than 50. And it's estimated that 1 in 18 people in New Zealand will develop bowel cancer. So in terms of numbers, comparing us to Australia and to the UK and America, obviously New Zealand 3,000 cases, Australia larger numbers, UK and America larger numbers, reflective of their larger populations. But as you can see, in most countries, it's the second or third most common cancer diagnosed, and also the second or third most common cause of cancer death. So this is another slide here, just showing in a different representation the incidence. It's taken from Bowel Cancer New Zealand. So you can see the darker colours, higher incidence rates, so New Zealand down the bottom there in a darker bluish colour. And then the next slide is the mortality data. Again, we're not, completely red, but we're in that darker sort of pinkish colour, which isn't great. So what do all of these people have in common? The answer is bowel cancer. So the reason for showing this is that it affects everybody of all walks of life and ages, male, female. So we've got up the top there, the late great Brazilian soccer star Pelé. There's Sharon Osbourne, who went through that quite a few years ago, Ronald Reagan, Kirstie Alley, Audrey Hepburn, Dame Judy Walter, cricket players here. So we've got Sir Richard Hadley, and then over the other side, Chris Cairns. And then of note, young New Zealanders and young people from overseas. So Black Panther star Chadwick Bosworth, just 43 when he died. This is Dame Deborah James, who's diagnosed when she was 35 and just passed away last year at the age of 40. Di Henwood, Kiwi comedian, just 43, who has palliative bowel cancer now. This one here with the stoma bag is Adele Graham. She is a radio DJ in the UK, and then Dean Barker, who went through bowel cancer while training for the America's Cup. So the colon, what an incredible organ. It's the human waste disposal unit. It's pretty amazing when it works well, not so great when it doesn't work well. Most of the time you chuck food in the top end, your body knows what to do with it, extracts all the goodness out of it, and then throws it to the large colon, where basically the purpose is just to convert it from being a liquid into a solid, where it's held in the sigmoid colon and then evacuated at a time that's suitable. So it's between 1.5 and 2 meters in length and housed all within your abdomen. So you've got the proximal colon, which makes up the ascending and transverse, and then the left or distal colon, which is the descending and sigmoid, and then the last 15 centimeters is the rectum. Polyps. So how do these happen? So just like your skin sloughs off cells, your colon does slough off cells, and you pass it in bowel motions. But for whatever reason, a little rogue cell might grow there, and then it divides and divides and divides, and basically becomes a polyp. So that's what we worry about, and that's a precursor to cancer. So as you can see here, on the left, we've got the benign, just small polyps, which might be adenomatous, and then as they grow bigger, risk of developing cancer, cancer within a polyp, and then through to invasive cancer. So in terms of polyps, how can we classify them? So you might read colonoscopy reports and see that they might be classified as sessile or pedunculated, and that's based on the endoscopic appearances. So two sessile polyps up the top there. So that one's a sort of flat sessile serrated polyp, and that one's just a little dome-shaped sessile polyp. Or pedunculated polyps, which basically sit on a stalk. So they look like a mushroom, and it's just the endoscopic appearance of the polyp. Then you can classify them based on their histology. So the adenomas either go down a pathway of tubular or a villus type growth pattern. Then you have serrated adenomas, you also have hyperplastic polyps and inflammatory polyps. So these are the sort of main ones that we worry about. You can obviously have other weird and wonderful polyps that grow, but I won't cover those today. So in terms of tubular adenomas, these are sort of what I call the garden variety type polyps. So 80% of adenomas, they're very, very common. They take years to form. The bigger they are, the bigger the cancer risk. So the image on the right beside that, so that there, which I'm circling with my mouse, is normal colonic mucosa, and that there is the tubular adenoma. So you can see dense purple material on the H&E staining, which is extra nuclear material, which is the adenoma part. So villus adenomas, like classified by the sort of finger-like or leaf-like appearance, which is quite obvious there on that low-powered view. 5 to 15% of adenomas, and they're also more likely to become cancerous. So then we have the ones that grow in the double pattern of tubular villus, where you can see on the left side of here, that's the tubular pattern, and then the other side is the villus pattern with the finger-like projections, and that makes up 5 to 15%. Serrated adenomas, so these serrated based on the word, on the term saw-like, which basically is talking about the crypt pattern that you see up the top here. So it does look like a jagged edge saw. And the crypts can branch in a horizontal pattern to the top part of the polyp, which is not the case in the other types of growth. The traditional, they can either be sessile serrated adenomas or traditional serrated adenomas. The traditional serrated adenoma has a high risk of becoming cancerous. So it's one that we do consider an advanced polyp, and one that we do like to keep a very close eye on. The hyperplastic polyp, basically benign. When you see it in the rectum or in the sigmoid colon, there's essentially no cancer potential with it. And then inflammatory polyps are worth a note, tend to occur in things like inflammatory bowel disease, and where they're known as pseudopolyps. Or they can happen in the setting of mucosal prolapse. So the New Zealand polyp surveillance guidelines were just updated in 2020, and it takes into account what type of polyp it is, the size of the polyp, and then when you would need your next surveillance. So you might see recommendations from us gastroenterologists saying, you know, they need a colonoscopy in 1 year or 3 years or 5 years, or it might be that you can stretch it out to 10 years or participate in the National Bowel Screening Program, whichever comes first, depending on their age. And it's, yeah, essentially risk stratification of the polyp. So the National Bowel Screening Program, I'm sure most people will have heard of this now. Most people will have seen the ads out there. This is the website. So it sits in conjunction with the other screening programs we have running in New Zealand, which is breast screening and cervical screening. So you can click on the link for bowel screening, and it's got the information if the patient wants to look it up, or if you want to look it up. So essentially the pilot program ran for 4 years from Waitemata, and then the national rollout occurred over 2017 to 2022. A little bit longer in terms of rollout time, just because of that sneaky little virus COVID, but it's now everywhere in New Zealand, so it shouldn't matter where someone lives, they should have access to the program. Free for people aged 60 to 74. They're basically sent an invitation, so invited to participate. They do the FIT test, which is what this gentleman is holding here. They do that at home, privacy of their own home, a little sample of stool, pop it back in the tube, put the sticky label on it and post it back in the return envelope, or drop it to the local lab as an option in South Auckland. So this is the timeline of the rollout. So you can see some DHBs have been on board since the beginning, back in 2017. For us at Middlemore, we came on board in July 2018, right through to the last DHB to come on board, which was Bay of Plenty just in June of last year. So still in the infancy for those guys. So this is how the screening program works. And I think most people will have seen some sort of flowchart like this before, where the registered population is picked from the NHI. They get invited to participate, they get sent the pack, and then depending on the results, whether it's negative, if it's negative, they get invited again in 2 years' time. So they keep getting invited. So if they're negative at age 60, they'll get invited at 62, then 64, then 66, 68, so on and so forth. If it's positive, then they go down this pathway and basically get pre-assessed on the phone. So you guys as GPs would do the referral through to us. They get pre-assessed by the bowel screening nurses, and then get offered a colonoscopy or an alternative investigation, which tends to be a CT colonography, depending on what we're hoping or why we're selecting that based on their comorbidities. And then after that, if they have polyps found, then they'll go into a surveillance program. So they'll get either the 1, 3 or 5 year surveillance, or if there's nothing found, they'll go back to the screening population. So they'll get invited again in 5 years' time. Equally, if we found something like a cancer, they go down the treatment pathway for that. So who should do the test? Essentially, a screening test is for asymptomatic people. So for people who are otherwise fit and well, so between the ages of 60 and 74. So people who don't need to do the test are people who have symptoms of bowel cancer, because we're going to investigate them whether the FIT test is positive or not. If they've had a total colectomy, they don't need to do the test. If they're already on a polyp surveillance program, or if they've had a colonoscopy within the last 5 years, they don't need to do the kit. If they've got ulcerative colitis or Crohn's disease, they don't need to do it because they'll already be getting followed up and already getting surveillance. So those are the people that don't need to worry about it. So as I mentioned, that's the little kit that gets sent out. So pretty small and discreet, and can be done at home. In terms of what we are finding, so these are all things that we found on colonoscopy. So the big image on the left there is a bowel cancer. That one there's a decent sized polyp with lateral spread there. That's another example of a lateral spreading polyp. We find pedunculated polyps like this one down the bottom and that one up the top, which we can take off. We find people with polyposis syndromes like this person here with all these polyps. We find hemorrhoids in some people. We find diverticular disease, which is this one with all the little outpouchings here. We find diverticular associated colitis, which is this one here. That one there's an inflammatory polyp, which we can find. This here is ulcers in the small bowel, which can be from things like non-steroidal anti-inflammatory drugs. We've also found people with ulcerative colitis. So this is completely asymptomatic people, which is that picture down the bottom there. That one's angioectasia, so just a little overgrowth of blood vessels. And that picture there off to the side is a sessile serrated polyp. So lots of pathology that can cause a FIT positive result. So it doesn't necessarily mean cancer. How are we doing? So this is the county's data as of July 2018 up until just the end of March, so quite up-to-date stats. So the total number of kits that have been sent out in our region is 181,523. The number of positive results, 3,700 odd, and number of colonoscopies we've done, 2,900, and then 232 CTCs. Average histology pots. So by that, I mean for every polyp or every sample that we take, it gets sent in a separate pot. So some people have no histology at all. Other people might have like 50 pots if they've got truckloads of polyps. But the average number is 4.25. And the number of cancers that we've picked up just in that time frame is 212. So definitely worthwhile doing. How are we doing nationwide? So this incorporates all the data from every DHB. Well, now the DHBs, I guess, are merged. So every centre that's running it. So some of them have been running it for quite a few rounds and others have just started recently. So the data's as of the 20th of February. So number of kits sent out nationwide, just on 1.3 million. About half of the kits returned there with 30,000 positive results. 24,500 colonoscopies have been performed and 1,832 cancers detected. So definitely worthwhile doing. In terms of staging of cancers, so this is just a refresher for everybody. So comparing T and M staging with the stages 1, 2, and 3. So obviously early stage cancer is just when it is in the mucosa or submucosa, and then as it invades through and perforates through to adjacent organs, or when you've got locoregional lymph node involvement, then obviously the stages are worse through to metastatic disease. So I guess then that begs to ask the question, how are we doing with picking up stages of cancer on the bowel screening program? So this slide I very kindly adapted from Susan Parry's slide that she presented at the Gastro Conference just at the end of last year. So to give you a bit of ground to compare things, so this is the bowel screening program, and by first screen we mean the first cycle of screening, which is a 2-year cycle. And then subsequent screens. And what the data is comparing with is symptomatic presentation. So this is patients who have symptoms of bowel cancer. And it was assessed on the Piper study, which looks at all the people that were diagnosed with bowel cancer in New Zealand in 2007 and 2008. So I know we're not comparing the same thing, but it just gives us an idea about where things are heading and whether we are able to pick up cancers at an earlier rate. So you can see there in the symptomatic presentation, over those 2 years, 12% of cancers were at the early rate, whereas on bowel screening, we on the first round, 34% of cancers early stage, and subsequent screening, 29%. So those with eagle eyes will probably notice that that doesn't all add up to 100 on each chart there, and the bottom number is just basically when the data hasn't been captured about what stage the disease is at. So bear that in mind looking at things. So my next slide is specifically talking about the Piper study, which was what I referenced back there. So it was done, as I mentioned, 2007 and 2008, looking at colorectal cancer survival in rural populations based on ethnicity and deprivation, and whether that had a difference in terms of outcomes. So they basically did a retrospective study looking at 4,950 patients. Over that time frame, 1,938 had died by May of 2014. And essentially they did find disparity in terms of outcomes of this cohort of patients. And most of this was explained by the stage of disease of diagnosis for Māori, but also for Pacific peoples in deprived areas. So bear that in mind when I talk about the next slide, which is age extension. So the program at the moment is running for ages 60 to 74, but as of this year, the age extension is rolling out for Māori and Pacific people, so dropping that age of screening down to 50 to start at 50 years of age. So Waikato and Tairāwhiti have already started doing this, and it's scheduled to roll out nationwide over the next year. So why are we doing this? Basically because the survival outcomes are significantly poorer in this demographic. 30% of the excess mortality is attributed to the comorbidities and difficulty accessing healthcare services, but also that Māori and Pacific people are more likely to present with advanced disease and are also more likely to be diagnosed when they present to the emergency department, which is usually with an obstructing bowel cancer, which isn't good. This is another way of looking at it as well. So Māori are represented as the red number, as the red line on this graph, and non-Māori as the blue line. And as you can see, their rates of bowel cancer the peak starts at a younger age, hence the rationale behind lowering that age bracket. So how are we doing participation-wise? So overall, about 58%. So for Māori, 49%, Pacific, 39%, and non-Māori, non-Pacific, 62%. So there's definitely room for us to improve people doing the kit. So I think as a GP, this is a key thing, that you can encourage people to do the kit because it's definitely worthwhile. It's easy, it's free, it's going to save lives. Early onset colorectal cancer. This is a topic that I think warrants acknowledgement and warrants discussion. Why am I saying this? Because these ones here, all down in the left corner, are under the age of 50. So diagnosed in his 30s, 35, just 40, 43. So something to bear in mind, not what you were told at med school about it being an older person's disease. It can happen in young people. So what's the data showing us? Everywhere we're seeing increasing incidence. So it's not just in New Zealand, it's happening throughout the world. So America, the UK, Australia, this is a little depiction from Australia saying it's the deadliest type of cancer for young people in that age bracket, 25 to 44. So it's not the podium that you want to be standing on. Yeah. So early onset colorectal cancer is defined as, in most literature, as people under the age of 50. The first case reports were back in 1939. It's definitely been an increasing thing we've seen over the last few decades and is expected to double by 2030. So currently, or if you look back at 2010, early onset colorectal cancer accounted for 4.8% of colon cancers and 9.5% of rectal cancers. But by 2030, it's expected to make up 10.9% of colon cancers and 22.9% of rectal cancers. So something to bear in mind when you see that young person with worrying symptoms. Don't just dismiss them as being too young. This is another graph from the Cancer Society of America, basically showing the overall trends. So you can see here for people over the age of 65, with black being localized disease, red being regional, and blue being distance, and then pink, which is down the bottom there, is unstaged. You can see their rates from 1998 through to 2018 have been decreasing, and that's credited as people doing the screening program. So 50 to 64, also kind of downward trending or plateauing, but this age bracket here is the increasing one for every group. So the localized disease, regional disease, and distant disease. So definitely something to bear in mind. What about data here in New Zealand? So this was published in just recently, so 2023, early onset colorectal cancer in Canterbury. And basically they looked at all of the cancer diagnoses that they had in Canterbury between 2010 and 2017. So that made up 3,340 cancers. 201 of them were cancers under the age of 50. So the other thing they found is that it tended to be distal left-sided cancers, and they often presented it in an advanced stage, though they tend to have a more aggressive phenotype than the older onset type colorectal cancers. So risk factors for colorectal cancer. This is probably one of the most common questions I get asked after doing a colonoscopy. How do I reduce my risk of forming polyps? How do I reduce my risk of developing bowel cancer? What do I need to change in my diet? So it's a combination of quite a few things, and I don't think we fully have an explanation and a full understanding of all the delicate interplay here, but it's a combination of genetic and environmental factors. So 70% of colorectal cancers are sporadic, and then the other 30% are attributed to hereditary or inherited type syndromes like Lynch syndrome or cell-ulcerated polyposis syndrome. Early onset colorectal cancer is not fully understood at all. There are obviously modifiable and non-modifiable risk factors involved in the development and why they get it at a young age and why it's more aggressive. So we do know in terms of modifiable risk factors, excess weight is a bad thing. Diabetes is also seen as a risk factor, presumably from the pro-inflammatory state if their blood sugar levels are high. Alcohol is an independent risk factor, tobacco also an independent risk factor, processed and red meat, so things like processed meats, not so great. Things that are protective, so things that I would suggest to people, fiber. And I said this to one of my endoscopy nurses about 2 or 3 weeks ago when she was asking me about what she could do with her diet. I said, fiber, and all the colours of the rainbow. So plenty of fruits and vegetables and physical activity, all good things. Non-modifiable risk factors, obviously you can't pick your parents, you can't take your family history. So whether you've got an inherited Lynch syndrome or FAP or some other reason that puts you at risk, it's just about being aware of that and being conscious and promptly investigating your symptoms, or if you have got a Lynch syndrome, getting tested and then seeing the familial GI service and getting their recommendations. And it might be that you have 2 yearly colonoscopies based on your family history and your gene profile. Inflammatory bowel disease, so if you've had ulcerative colitis for a long period of time, and if you've also got primary sclerosis and cholangitis, those are also risk factors for colorectal cancer. You'd be under a specialist care for this, and they'd be keeping a close eye on things and recommending surveillance. So this is basically showing the same thing. So they're saying bad things are red meat, processed meats, having lots of alcohol, being overweight or obese, and then good things are, plenty of fiber, whole grains, and being physically active. So showing in another way from the Bowel Cancer Australia, the green things up the top, as we mentioned, and then red things down the bottom, not so great. So I've got a few cases to go through. So some patients that I've scoped on the bowel screening program and some that I've scoped via the symptomatic service. But just to give you a picture of what I see on a daily basis. So the first case, Mr. C, 65-year-old Chinese man, so he's in bowel screening age. He did his FIT test and it came back positive. He's got no family of colon cancer, but did have a radical prostatectomy a few years back for prostate cancer. So my bowel screening nurses phoned him and invited him in for a colonoscopy, which he came along to. So what you're looking at here is the terminal ileum, which means I've gotten all the way around the colon. There's a little polyp there that I'm circling. So that's a sessile serrated polyp. It's pretty flat and small, and this is just by the appendiceal orifice. So that one I took off. There's also this polyp here in the sigmoid colon, which is pedunculated, which I took off as well. And that's the post-polypectomy images that you're looking at there. And then the last picture there is me retroflexing in the rectum, which basically means I'm hooking around like an umbrella handle, looking at the rectum from the inside out, purely because the camera is forward viewing and we don't want to miss stuff in our peripheral vision. So in terms of what polyps the histology came back as, so that, as I mentioned, that cecal polyp was a sessile serrated polyp. That's pedunculated sigmoid one was a tubulibous adenoma. So based on the polyp surveillance guidelines, he goes for a surveillance colonoscopy in 3 years. So definitely worthwhile him doing, because this, if we'd left it, would have eventually turned into a cancer. So great outcome for him. Next patient, Mr. K, 60-year-old Tongan man. So 60 on his birthday, he got the centre fit kit. Did it. No family history of colon cancer. Of note, he does have type 2 diabetes, HbA1c of 85, so not the best glycemic control there. High blood pressure, he's got obesity with a BMI of 34.5. He's also got chronic Hep B, isn't on treatment, is just under surveillance through the Hepatitis Foundation. So I was getting 6 monthly blood test monitoring, and his liver function tests are actually normal, which is excellent. This is his colonoscopy. So first image up the top there, his terminal ileum. And then what you're looking at in all of these other images are a whole load of polyps. So there's hepatic flexure polyps there and there. There's an appendiceal orifice polyp there, another one in the transverse colon, another one in the transverse colon, quite a few, one there on a pedunculated long stalk, and then a few more down here. So yeah, plenty to harvest. So all in total, 15 polyps I took off. Vast majority of them tubular adenomas, but because of the number of polyps that I took off there, he warrants a surveillance colonoscopy in 1 year, and he also was referred through to the Familial GI Cancer Service. So definitely a good outcome here, and that he's had all these polyps taken off so they can never turn into anything, but also really good outcome for his family. So because he's the index case, so he's 60 and he's been diagnosed with all these polyps, when he does get seen by the Familial GI Service, they'll sit down and do a pedigree chart and make recommendations for his family members. So potentially this has been a life-changing moment for his family. Next case, Mr. H. He's a 60-year-old man, also got sent one on his birthday. Forklift driver, fit positive, also through the National Bowel Screening Program. He does have a family history of colon cancer. He's told me his mum had colon cancer in her 50s and also a maternal aunt in her 60s. His only background history is BPH. He's just on doxycycline, no other medications at all. So I did his colonoscopy, and this is what I found. So the two, that is the cecum, so the appendiceal orifice here, that's ileocecal valve off to the left there. These two middle images are two small polyps that I took off. But the most concerning thing is the images down the bottom, which is essentially a cancer. So that nasty ulcerated growth that you're looking at there is the cancer, which I could traverse with the scope. And then the last image is me tattoo marking it. So after we diagnose a cancer, we put 3 tattoo marks distally. So when he goes for surgery, they know exactly where the lesion is. So these are his blood tests after the colonoscopy. So CEA levels normal, the rest actually look pretty pristine. So completely asymptomatic, just did his fit test. So no symptoms despite that looking like a decent sized tumor. So he, this is the biopsy results. So those small polyps were a sessile serrated polyp and a tubular adenoma. The one of concern is the adenocarcinoma. So that was in his distal transverse. And then they do the additional stains to check for mutations and prognosis and treatment options. And so this is the CT imaging. So you can see it was December of last year that I did his scope. So I'm sorry, it doesn't show up the best, but essentially that's his liver there. This is his left side and this is his right side. And the transverse colon sits across like this. And this is the thickened area here. And the fluffy stuff inside there is stool. And then this is another image. So all that fluffy stuff is stool, and that's the thickened area, that's the tumor. So no liver mets on the imaging, which is good. So this is his surgical specimen, for after his right hemicolectomy. So he's a P2, T2, N0, M0. So he's a stage 1 disease with no lymph node involvement. So we consider him curative after having the surgery. So again, definitely worthwhile him doing the bowel screening kit. We've picked up a cancer. If he'd waited for symptoms, he definitely would have had much more advanced disease. Case number 4, Mr. R. So he's a 50-year-old male and a builder. He was referred through the symptomatic pathway, so he wasn't part of the bowel screening program. He had symptoms, which were a change in bowel habit for 3 months. He just said to me he was going to the toilet more often than what he used to. It had some intermittent bouts of PR blood loss, and then also had a family history of bowel cancer. So dad when he was 60, grandfather when he was 70, and grandmother in her 70s as well. So these were his blood tests with the GP. So completely normal blood count, completely normal ferritin. But this is what I found. So in his sigmoid colon, and a bowel cancer. So again, I could traverse this, and the rest of his colon was pristine, no polyps. And then me tattoo marking it. Came back as an adenocarcinoma. And then he's also had CT imaging. So down here, you're looking at the sigmoid, and that fluffy stuff is stool, and so that thickened area there is where the tumour is. So just in the sigmoid, last bit of the bowel, and then you can see in him as well, thankfully no liver mets. So this was just in March of this year, so just last month. So he came forward for surgery. He had a low anterior resection, which was done laparoscopically. He's come out as T3 N0 M0, so stage 2A, which, yeah, again, really glad that he came and presented when he had symptoms and didn't just put his head in the sand and say this will pass. So I guess then that leads us to what are the take-home points, and I guess what's the bottom line here? Bowel cancer, 3,000 cases a year in New Zealand, so keep your eyes out for it. Can happen at any age. No one's too young to have it. Bowel screening program, definitely encourage people to participate, advocate for the program, save their life. The earlier the cancer's picked up, the better the outcome. So yeah, definitely worthwhile. Tips to reduce cancer: stopping smoking, avoiding processed meats, making sure you're not gaining excess amounts of weight, not drinking too much, not smoking, just plenty of fibre, being physically active, and participating in the program. So I think we can probably go on to questions, and then yeah, have a panel discussion with myself and Ian.
Okay, Adele, that was great. Nice to have someone who's so enthusiastic about the gastrointestinal symptom. You get the prize for that. Okay, so Jonathan had asked, is a sessile serrated adenoma as opposed to a traditional serrated adenoma benign?
So sessile serrated adenoma and a traditional serrated adenoma are not just benign things, so they can potentially turn into malignant type growths. So yes, we would like to take them off during a colonoscopy.
Next one is from Peter. What should be the frequency of follow-up colonoscopy after bowel cancer? And I have a supplementary question. Somebody who has a normal colonoscopy, say mid-60s, does a bit of the FIT tests, they're all negative. Do they need a colonoscopy? So 2 questions.
There are clear guidelines in terms of where the cancer was and like the stage at which they had it and what treatment they've had as to when they need their surveillance. And so most patients like that will be under the care of a colorectal surgeon. And it also depends on whether they actually had a full colonoscopy at diagnosis. So if they haven't had a full colonoscopy, as in if they've got an obstructing lesion and you haven't assessed all of the colon, they tend to get a very early follow-up scope to look at the rest of the colon. And then their surveillance will depend on what you find on that early follow-up. So if you found a whole load of polyps in the proximal colon, then they might get one in 1 year, or it might be 3 years. So it depends on what you've found, but usually that would be directed by the colorectal surgeon. And then the second question was about someone who's had bowel cancer who then does a FIT test.
No, somebody has a normal colonoscopy, say in their mid-60s and their 60s, then has normal FITs. Would you suggest they need a colonoscopy, a screening colonoscopy downstream, or could you just leave them?
I would just say to them, keep doing the FIT test. So they'll keep getting sent it every 2 years if it's negative, up until the age of 74, at which point we can say, yeah, that's pretty good. Obviously, the caveat to that is if they do develop some sort of symptoms that are concerning, then that warrants investigation. So I don't know of any medical test that is 100% sensitive and 100% specific. So yes, there is a very, very small number of people who can have a negative FIT test and have a cancer. So it's relying on the fact that the cancer's bleeding at the time that you do the FIT test.
Okay.
So
and what would those symptoms be? What would be your key symptoms for a clinical presentation?
Yeah, so Good question. Persistent change in bowel habit, so lasting for more than 2 weeks. If they've got rectal bleeding, if they've got iron deficiency anemia, or if they've got like a palpable abdominal mass, yeah, or family history.
Family history, great. We're getting some nice short questions here. Someone with IBD, I'm presuming that's irritable bowel.
Inflammatory bowel disease.
Sorry?
Inflammatory bowel disease, so ulcerative colitis or Crohn's.
Oh, okay, IBD, okay. Have had no flares for a long time. Can she have a fit? She have a fit?
So it depends on exactly the IBD as in what is involved. So if they've got something like ulcerative proctitis that's essentially in remission, then yes, they could do a fit test and that would be fine. If they've got Crohn's disease involving everywhere in their gastrointestinal tract, their fit is probably going to be positive quite a lot of the time. So what I would say is I'd discuss it with the gastroenterologist who's looking after the patient, because they'll have an idea about when they need surveillance for whatever reason and whether it's actually going to be useful. And saying that, I have had a whole load of patients who have ulcerative colitis and Crohn's disease who have done the fit test and come through positive, that we sort of manage accordingly. So it might be that they end up getting a colonoscopy through the symptomatic pathway than actually one from the bowel screening pathway.
I've got a tricky one here. So oral calcium tablets can reduce risk of CRC. What's your view on that? Because the concern, of course, of taking calcium tablets is cardiovascular disease.
Yes. I must say, it's not something that I ever recommend to my patients because obviously risk of cardiovascular disease. So I would just say, just eat a diet that's containing enough calcium, would be my suggestion. I wouldn't go adding calcium tablets.
That's a nice one. When you take out the polyp, is it from the base? If so, what is the percentage of recurrence at the same spot?
So the ideal thing when we take off polyps is that we completely resect the whole thing. If there is question of doubt or concern that we haven't resected it, then it might be that we do an early surveillance, in which case we'll sort of diverge away from the surveillance recommendations. So it might be that we say go back and have a look in 6 months. And do a site check and take samples. Equally, if it's on a stalk, we usually get really good views after taking it off, and we're usually very confident that the growth is actually in the top part and the stalk is actually normal mucosa. It's just got the feeding blood vessel in it. So those long ones, those long pedunculated type ones tend to basically be from mechanical trauma. So they often are in the left colon, so they might be in the sigmoid. Basically, as stool goes past, it's pulling it and tugging it.
The questions are roaring in. Any you want to answer, Ian? Have you got one there you want to have a go at, or one jumping out at you?
This is from Yaj. Should fit screening be offered to people below 60, 40 to 60-year age group? Well, the evidence really is from patients or from a population over the age of 50. We don't have evidence for benefit of screening below that because although the incidence is increasing, it's still very low. I would expect within the next few years in New Zealand, we'll be doing it not just for Maori and Pacific from 50 up to 75, but we're beginning with Maori and Pacific because for them, the bigger proportion of their patients with colorectal cancer happen at a younger age because of their population bell curve, if you like. So they have a lower age of overall life expectancy. Does a negative CT colonography exclude malignancy, or shall we refer the patient for colonoscopy if the patient is still symptomatic? I think we can say a CT colonography, which is well done, has as good a sensitivity at identifying a cancer as a colonoscopy. And there are several studies that have showed that. Can you comment on sensitivity of CT colonography in finding colorectal cancer? Obviously that's the same question.
Yeah, okay.
How worrying is the symptom of bloating in young people? It is very worrying for the young people, but it is not a very helpful symptom in identifying pathology. And we see a lot of patients who have had many, many investigations for bloating with very little yield. But anyway, I would usually send them to a gastroenterologist.
Yes,
That's
it's
a
sort
good
of,
call.
I
And
can
I
imagine
would
that's
say that
certainly.
bloating, the first test wouldn't be a colonoscopy. We'd usually sit down and work through a whole load of other things first. It wouldn't be top of my differential diagnosis.
Okay.
So
The
so there
question
are,
here is FIT
Yeah.
available in pharmacies privately?
yes, it is available in pharmacies privately. The concern is that people under the age of 60 start doing basically screening of themselves. And at present, what happens to those patients varies across the country, I think. And if patients are going to buy their own FIT test, they may need to buy their own colonoscopy as well. So that I think the practice across the different hospitals in the country vary, but with the pressure on colonoscopy, a positive FIT test in an asymptomatic young person is, I think, unlikely to score a colonoscopy in the public sector.
Your fan, you got a fan here, Adele, that I mentioned before. Thank you so much. I heard you're the Goodfellow too. Brilliant. Quick question. Is one of 3 FOBTs positive? How do you go about it?
Yeah, so that's a good question. And FOBTs have kind of been sort of screened out in favour of the FIT test, because FOBTs would give us false positive results. So if they'd had raw red meat the day before, or if they'd had beetroot, then it can sometimes give a false positive result. I guess my question is, why was it being done in the first place? Was it that they had symptoms, or was it that they were concerned, and what were they hoping to get out of the result? So I guess what I'm saying is I wouldn't disregard it, but I want to know in what context it was being done as to which way to direct them.
Okay, does celiac disease increase risk of CRC?
The answer is no, which is good.
Nice. That's nice to know. I noticed the thing that you had about drinking milk was quite good as a preventive for bowel cancer.
Yes.
That'll make the farmers very happy.
So the calcium part of the milk is
calcium,
good.
okay, so
yeah,
don't take calcium tablets, but drink milk.
Just drink the milk is fine. I guess what I would say as well is it's diet is definitely an area of interest. So I know at the moment here at Middlemore and also at Waikato, they're doing an investigational study looking at selenium, because our soils in New Zealand are quite low in selenium. So you can get selenium from things like Brazil nuts. So they're looking at basically supplementing people who've had polyps found on a colonoscopy, on their index colonoscopy, and seeing whether that reduces the polyp formation. The data isn't back yet, obviously. It's still in the developmental phase, but definitely diet is an area of interest.
Among the epidemiologists, selenium deficiency is still looking for a disease, I think, isn't it? So,
yes, it is.
Maybe you'll find it. Maybe you'll find it. Okay, I also have a question. This is from the fan club. A question read, Maori population getting early FIT. How long do you wait for the rollout? Do you think if we get a family history we should initiate referral?
I think if you've got a family history of multiple first degree relatives, then yes, they just warrant a referral for investigations. I wouldn't wait for the FIT test.
Okay.
I think there's a good question from Sashi. 2 patients I know diagnosed with colorectal cancer a year after a negative bowel screening test. That's an important question. So the bowel screening test does miss some of the cancers. So anyone who develops symptoms, having had a negative FIT test in the screening program, should definitely see their GP. And if their symptoms continue, they should have a colonoscopy. So it's not 100%. It's probably finds around 70% of the cancers in the population if in the screened members of the population. So it does miss some. If they're not bleeding at the time that the test's done, then the test will be negative.
I guess that would be a question I've got for the two of you. I know there's a quantitative measure of the blood. So somebody who just misses the cut, are you going to pick them up the next time? What happens to people with sequential FIT tests that are below the threshold? Do you have data on that?
I don't have data on that. I do have, there was a recent study looking in symptomatic patients and doing FIT tests on those, and that's an interest of mine. And what they showed is that they increased their sensitivity if they did 2 FIT tests 2 weeks apart. And so that There were some who had the second FIT test that was positive, and they ended up getting a colonoscopy, and that increased their sensitivity from around 85 to around 95% in the symptomatic patient. So that's a different population.
Right. So the pre-test to be higher there, wouldn't it?
Mm.
Yeah. Okay. If a patient is FIT positive and has had a normal colonoscopy, say 3 or 4 years before, should they still receive a colonoscopy under the NBSP?
So I can answer that question, and that's one that we see quite a lot. So it may have been that the colonoscopy that they had 3 years ago might not have been adequate. So that's something that we always like to look at. So before we go saying yes or no to a colonoscopy or yes or no to a CTC, we want to see, first of all, was the bowel prep excellent, and did they get really good views? Because if the bowel prep was suboptimal, there'd be grounds to say they need a repeat one. And then did they get all the way around the colon, or was it just abandoned halfway? And is that the reason why, you know, it wasn't fully investigated? So it in that situation, when a FIT test comes back positive, my bowel screening nurses would phone the patient, then they'd obtain a copy of the previous colonoscopy report, and then we'd make a decision about whether it needs to be repeated or whether the recommendations from that report are sufficient.
Yes, so here's a question from Anonymous. Can someone pay for bowel screening outside the screening age group? That goes back, presumably that's the FIT test, you can pay for that. I guess the hassle there is you've got to be willing to pay for the colonoscopy should you get a positive one. So you might embarrass a patient because they pay for the FIT test and then they get a positive, and then what do you do if they can't afford the colonoscopy? Yeah, any suggestions on that one?
I guess, yeah, you go, Ian.
No, I think it's a curly one. The problem that we have at present in New Zealand, and exacerbated by COVID, is that there are many places where the colonoscopy capacity is completely stretched, and the waiting lists have got very long for people who really do need colonoscopies. And for asymptomatic patients who are asymptomatic people who are under the screening age, the younger they are, the more likely they are to have a false negative test. Sorry, a false positive test. So that they'll get a positive test, but they are still very unlikely to have a bowel cancer if, for instance, they're 25, unless they're symptomatic. Now, if we look at patients under the age, people under the age of 50, then there's less than 1 in 1,000 that will have a bowel cancer. And even if they all have a FIT test, we actually don't know how many of them will actually turn up a positive FIT test, but you'll be much more likely to have a bleeding hemorrhoid or an anal fissure or some other reason for some blood in the GI tract than a colorectal cancer. So one of my take-home messages would be, if you have a patient with PR bleeding, which is continuing and is undiagnosed, they need to be seen and they need to be diagnosed. Those are the patients that we sometimes see at the age of 30 and they've had bleeding for 5 years, and everyone's thought it's their hemorrhoid perhaps, and they've never been adequately assessed. The second thing I would say is that under the age of 50, 80% of the cancers occur downstream of the splenic flexure, that's in the left colon, and at least half of those in the rectum. So if it's a young patient and they've got PR bleeding, you will be able to feel about 1/3 of the cancers that are there with your finger. So do a rectal examination in that setting. That would be the most important thing I can tell you. Patients who are young, who have continued bleeding, need a diagnosis rather than just continuing thinking, oh, it's going to get better. Patients with vague abdominal symptoms like bloating and constipation almost, well, their chance of having cancer is actually very low, but they may be your most persistent patient. That's part of the problem.
That's right. Okay, so given that people are living longer, should the surveillance age be increased above 74?
Yeah, I can probably answer some of it. So if someone returns a FIT positive when they're 74 and they have polyps found, then the recommendation might be that they get one more surveillance and then we stop. But at that point, if they do develop small polyps, they're probably never going to cause them any problems in their lifetime. So if they just develop a couple of small tubular adenomas that are sort of 3 or 4 millimeters, they're never going to turn into anything. So putting an 85-year-old through a colonoscopy is actually probably going to be higher risk than what you're going to achieve out of doing it. Would that be a fair comment, Ian?
Yeah, there was a question about the harms of colonoscopy. What is the perforation rate and serious complication rate?
So in terms of taking biopsies or taking off polyps, so risk of bleeding is about 1 in 1,000, risk of perforation about 1 in 10,000 is the data that we quote people. Obviously, if they're on blood thinners, that's slightly higher risk. But yeah, it's about weighing up risks and benefits with any test.
Well, that's right. Yeah. And I take your point that you do occasionally miss some. We tend to think of colonoscopy as gold standard, but they do miss the occasional ones, don't they? Which I imagine must give you guys nightmares.
Yeah.
Yeah.
Mostly, it is perhaps more common than you think. Probably 4% are missed with a colonoscopy. And
nothing happens, I guess, for most of those.
No, well, they present later symptomatically.
Oh, right. Okay.
So yes, a good colonoscopy can still miss a small cancer, and there are particular places where you need to look very carefully, like the flexures and like the lower rectum. If the scope goes in and you don't retroflex and have a look back at the anus, you can go right past a cancer as the scope goes in. So yes, it can be missed, and the miss rate is somewhere under 5%, but is not zero.
Okay, so 2 patients I know diagnosed with colorectal cancer a year after negative BSP result at age 59. Query: yearly fit?
So I guess my first question is, where did they get their fit tests from if they were 59? Because they wouldn't have been sent through the bowel screening program.
Oh, okay.
And then I guess then my question to someone who's 59 who's doing a fit test, is it that they are worried about something, or is it that they've got a family history? Like, why have they gone and invested and bought one? Was there actually something else grumbling away?
Okay.
Yeah, in terms of family history, I think we can't emphasize that strong enough either. So if you have a young patient with PR bleeding, don't forget to ask them their family history of bowel cancer, and try and make it part of the routine questions you ask of people with bowel symptoms, because there are a significant number of patients with syndromes in the population.
Yes, I was taken with that 25% figure you had of people with some sort of
familial predisposition.
I guess, how many polyps to be considered for familial polyposis genetic testing?
So what the histopathologist will do on a bowel screening colonoscopy is, if they get more than 10 adenomas, or if they've got a whole truckload of sessile-serrated polyps, they'll make a suggestion and say, needs consideration for a polyposis syndrome. The other thing they'll do is, if they've had colonoscopies in the past, then they'll join together the histology results, and they'll say over the course of 10 years, they've had, 60 or 80 polyps. This is probably something which is,
right.
Very, very sensible.
I'm just trying to imagine a truckload of polyps, but the mind boggles.
That's a graphic description on my behalf.
That's right.
That's what it feels like when you carry the polyp bags with every single individual one in it.
This is sort of gastroenterologist locker room talk by the sounds.
Yes, maybe a very black sense of humour, I guess.
No, I imagine some days it's like that. So what is the incident rate of children being diagnosed with bowel cancer?
It's very low. In the age from 0 to 24, the number of colorectal cancer registrations is 1.3 per 100,000. So it's 0.001%. We do see some, and we have seen, I would say, more in the last 10 years than in the previous 30 years I've been practicing. And they are usually distally, or they're associated with a syndrome, particularly FAP, familial adenomatosis polypi, and for them, they will have a truckload, inverted commas, of polyps. So it's very rare in people under the age of 24 and exceedingly rare, almost non-existent under the age of 16. But we are seeing people in their late teens with rectal cancers occasionally.
Mm-hmm. I'm intrigued that the incidence increasing in younger people, and you mentioned obesity, presumably dietary things. Is there sort of, presumably there are case control studies. They seem to be going out of fashion now, but presumably they've been done overseas looking at fast food, perhaps. I mean, we eat more. My impression would be people eat more fast food these days than 50 years ago. There's so many more outlets. Do you have a view on that at all? Oh, the other thing would be alcohol. I've just been reading Guy and Espina's book about alcohol and pointing out just how many. It's a good read, I might say. We're hoping to do a podcast with him, which will be interesting. Interview the interviewer, but I think we underestimate the harm with gastrointestinal things with alcohol and breast cancer too. I mean, I think a lot of women don't realize, the alcohol and those sort of things. Any views on the dietary stuff and why it's all changing?
Well, there's quite a few questions you've put there, Bruce, but
Sorry.
I would say one, in terms of alcohol, it is the most denied reality, unfortunately. When I mention it at the parties I go to, I'm looked at rather sideways.
I think
but
you're a wowser, probably.
Yeah. I'm not a complete wowser, but I probably should be. There was a very interesting study in the Lancet that looked at the increased cancer risk associated with drinking 1 bottle of wine per week. And it was equivalent to the cancer risk of smoking 5 cigarettes a day per male, or 10 cigarettes per day per female.
I actually had a gym on
That's
that
one
some
bottle a week would just about be everyone on the webinar, I suspect.
Well, Guy and Espina had a pretty killer statement. He says New Zealanders have the same blind spot about alcohol that Americans have about guns.
Oh, that's.
I thought that was pretty telling, actually.
Yeah.
So we should get him on, I think, so we could quiz him. But yeah. No, the thing about I think the gym was how many cigarettes in a bottle of wine, and people went yuck. But actually, I think that's a good way of. And the other thing was the Lancet had a thing a few weeks ago, just saying Australia and New Zealand actually have the highest rate of harmful drinking. We lead the world.
Oh dear. Okay.
Got a way to go there, I think. Now, Ian, when I asked you about the risks of colonoscopy, and I think we got on to the risks of missing things, but the harms from colonoscopy, did we talk about perforations and things?
Yeah, we did.
Yeah, okay, yep, right. So let's go. In which patients are CT colonography recommended as opposed to colonoscopy?
Do you want to take that, Adele?
Yeah, I can take that one. So for the bowel screening program, all of the patients that the bowel screening nurses would assess over the phone, they discuss with me. So the ones that we tend to opt for a CT colonoscopy, it would be someone who's had a very difficult colonoscopy in the past. And it might be that they've had really nasty sigmoid diverticular disease and they found the procedure really painful, or they had muscle hypertrophy and it was really tight and they had to use a pediatric colonoscope. So in that type of situation, physically, it's a technically difficult study to do. And a CT colonography will actually give us the answers that we're after. So that type of patient would be one. The other type of patient that we tend to see a lot at Middlemore is the patient that's got metallic heart valves and is on warfarin, in which case we can't actually allow the level to drop and they might not be happy to give themselves Clexane, bridging over that time frame, in which case we would opt for a CT colonography. And then if we find polyps, we decide about how we're going to do it, whether they get trained by a practice nurse how to do the injections or whether we arrange someone to come out and do the injections. It tends to be that type of candidate that goes for it. Obviously, there's merits to both options. With a CT colonography, they wouldn't get sedation, so they can drive themselves to and from the appointment. They just drink the bowel prep. It's a similar type of bowel prep to a colonoscopy beforehand, and then they basically get a little probe popped up the tail end and just their bowel gets inflated with gas, and then they kind of get rolled around like a rotisserie check in on the CT scanner looking for polyps, and then they go home the same day. So yeah, it's good at diagnosing things down to polyps the size of 5 millimeters, so it's not going to pick up stuff smaller than that. But obviously that you can't actually take polyps off at the time. So if someone wants a definitive test where they're going to get their polyps taken off all at once, then a colonoscopy is the better option for them.
Yes, and then you're reducing the risk of subsequent bowel cancer, aren't you? With getting rid of those polyps. Opinion on aspirin as CRC prevention. What age? How much?
So that's a very good question, and it's one that's been discussed quite a lot in the literature. And so basically they've looked at people on aspirin and people who are on non-steroidal anti-inflammatory drugs. So the pathway is cyclooxygenase, via that pathway, and reducing the risk. From the studies have suggested that it does reduce your colorectal cancer. I haven't ever given a patient aspirin for that specific reason. I've had patients who've got cystic polyposis syndrome who've joined into studies overseas where they've been dispensed aspirin as to try and reduce their risk, but it's not something that we routinely would do here in New Zealand. Would that be a fair comment, Ian?
Yeah, I think there are patients who have a polyposis syndrome for whom aspirin is being given in New Zealand.
Okay.
So there are those who recommend it, and so yes, it is preventive. The problem in a patient who doesn't have multiple polyps is the side effects of aspirin, and that has to be the balance. But it's supposed to be good for your heart too, isn't it, Bruce?
Well, it depends on your age, and that keeps changing. We've got to stop it at 80, so okay for 50 to 60, but not over the age of 80 because of the GI bleeding, basically. I guess you guys sort of see it. So I think the aspirin for CVD, primary prevention anyway, is still a work in progress in spite of hundreds and hundreds of studies. So it's secondary prevention is a no-brainer, but primary prevention is quite different. Interesting question here about carcinoembryonic antigen. So what are your thoughts of that in patients with mild symptoms such as non-specific abdo pain or bloating?
It's a waste of time.
Googling them.
Yes.
It's a waste of time. So CEA is only useful in follow-up of patients who've already had a bowel cancer, in terms of bowel cancer, that is. CEA is not a screening test for a new bowel cancer because the chorioembryonic antigen is actually broken down on the first pass through the liver, so it will be normal even with a big bowel cancer. And what we're looking for is, with a CEA, is a cancer that's spread outside the portal system. So it's in the systemic system somewhere, either in the liver or the lungs, and that will give you an elevated CEA. There's a couple of questions about diverticular disease. I would say one, diverticular disease does not increase your risk of having a bowel cancer. But what about a patient who has diverticulosis with ongoing diarrhea? How would we know when to refer for colonoscopy? Adele, how would you answer that?
Yeah, so I guess if they've got diarrhea all the time, I'd want to know, have they actually had a colonoscopy at some point? And have you actually diagnosed the diverticular disease? Or is there some other overlap going on? Is it that they're in that age bracket where they've got microscopic colitis and that's the cause of their diarrhea? Or is it that they have actually got something else grumbling? So I'd want to know, what have they been investigated with before? Have they had a CT scan or have they had a colonoscopy? And then, manage things accordingly. So if they've had a diagnosis of diverticular disease, are they getting diarrhea all the time because they've just got recurrent diverticulitis and they're systemically unwell with it, in which case I would have thought they would have had some sort of imaging and some sort of investigations. It's a difficult one, but it's all about patterns of bowel habit and what they've tried to try and improve things in the past, and whether they've tried bulking agents and other bits and pieces, I guess. So it would be a matter of taking a really good history from them and then reviewing their notes about what they've had investigated before, I guess, would be my approach to it. Would that be a pretty fair comment?
Yeah.
Does the issue of pain with bowel cancer, this comes back to your comment, Ian, for early symptoms, is pain a usual one?
Pain is an unusual one as an early symptom. And if it's pain that's associated with a bowel cancer, then that would usually mean it's actually relatively advanced. Unless it's a very low rectal cancer. And then they can have anal pain associated with a rectal cancer. But Pain is not usually a symptom.
So we've got probably more questions than we've got time. So when one of you is answering, the other one could be scanning for key questions. So is there an age just to check your colon out if you've got private cover, i.e. 50, or do you think we should encourage patients or ourselves to do this? Not sure what the last bit is there.
I think it's saying, I mean, it's talking about would I go and get a colonoscopy when I finally turn 55?
Right.
I think
Well, when you turn 55, Ian, we'll pay for it, quite frankly. You'll have discovered the elixir of life.
so. I don't think I can give any very good advice on that. If you can afford to have a colonoscopy, should you go out and get one if you're completely asymptomatic at the age of 55 and you have no family history? I think I can't really recommend it, but I know that lots of people do.
Yeah, I think
very fashionable in America, isn't it, to get your
fashionable in America and the UK and Australia. Yeah, they will just do it as a sort of general body warrant of fitness. So I think that's
academics when they come here usually have a colonoscopy. One of them actually had one missed, and she actually had bowel cancer and went back to the US eventually. So no guarantee, but probably not a bad idea if it's paid for in America. Are you likely to change the FIT test for a more sensitive one?
The FIT test is actually very sensitive. We set the threshold of it in the screening test to a balance between screening a huge number of people who don't have a cancer and not missing many cancers, so that there is the actual threshold for the bowel screening program is 200 units as opposed to 75 units that it was in the pilot study. So if we had a huge surplus of colonoscopy capacity, which I don't even think America has, then we might decide to set the threshold for a positive versus a negative test at a lot lower, and we would do 5 times as many colonoscopies and find maybe 20% more cancers, if that can answer your question. So I don't think we're suddenly going to have a different test. We may have, there is another test for following up bowel cancer. Now, that was a question someone asked, and one of the there is a protocol for following up after bowel cancer, and we would usually do CEA, we would use a CT scan, and we would do a colonoscopy, usually at 1 or 2 years. And if they've had chemotherapy, we might do it at 5 years to look for metastases. That varies a bit across the country, and that is going to all stop because there's a new test, and that's circulating tumor DNA, a simple blood test, and it will do away with doing CT scans and doing CEAs. And it's not far. It's already starting in UK in studies, and I'm sure it will go global quite quickly. So that will make it a lot easier, and it's more sensitive. You find cancers more quickly than with a CT scan. And so there'll be people then will be waiting for it to appear on the CT scan when they've had a positive circulating tumor DNA test.
It'll be sort of nirvana, won't it? Pick up the cancers on a blood test. I mean,
Yeah, I don't know whether it'll overtake screening. It might. It might for people who don't have bowel cancer, but it depends how expensive it is and how sensitive it is. But
so here's a curly one. If the FIT test is positive, is under 60 years, does insurance cover the colonoscopy?
I think he should ask his insurance agent that. I think there may be some that would.
Yeah, that would be. Do you have a experience with that, Adele, when you're private work?
Yeah, in private, most insurance companies would cover it.
Right. Okay. Yeah, I guess they don't want to upset the customers, do they?
I guess also it's a relatively straightforward thing for them to do, and if it picks up something like a cancer, then they obviously get treated and sorted. So I guess like a private colonoscopy is about $2,000, so it's probably worth it from a medical insurance perspective for them to do.
Question here about you mentioned ferritins, low ferritins. I'm seeing more and more low ferritins, but in people who are vegetarians, and I've been chasing, and I'm sure my colleagues are chasing more of these, but do you recommend scopes if iron deficient but not anemic?
Yes, we are doing scopes for people who are just iron deficient. So depending on what things look like and what's likely. So obviously if it's a young female who's iron deficient, then we wouldn't usually accept that as a referral. We'd probably say investigate for menorrhagia. But yeah, if they're just iron deficient and there's no valid explanation, they're not a blood donor, they haven't got, excess amounts of epistaxis or something like that, then yes, we would usually go doing it. It might be that we do it sequentially. We might just say we'll do a gastroscopy first and see if we can pick up something, and if we find an ulcer, then we can, kind of leave things be. But obviously, if it doesn't answer things, then we'll often go looking further.
Someone asked a question here about robots doing colonoscopies. It'd be too hard, wouldn't it? I mean, I think you can do prostate surgery with a robot, but not colonoscopy. You still need an operator.
It's not far off, Bruce.
Oh, is that right?
No, it's not far off.
So there is
doing the whole thing without a human. Wow.
There's some artificial intelligence type programs, so AI type programs, where when you do the colonoscopy, it puts a square around the colon on the screen for you and tries to pick them up and try and improve your adenoma detection rate. But yes, it's definitely an area of interest, and definitely technology is working on it.
Is there follow-up for those people who don't return the FIT test?
It's a good question, and yes, if they're in a high priority group, they do get followed up. So if they're Māori or Pacific, then they will get phone calls from the National Screening Unit, or our local DHB equivalent of DHB, or our local centre will follow up. So we'll try and contact them using our data, whether it's an up-to-date phone number, or if it's someone that moves address frequently, which can often happen in South Auckland, they'll go digging a bit further and try and figure out why they haven't done it.
Yeah.
So just for the high risk populations. Yep.
But there are dashboard reminders for GPs, I think, if someone has not returned a FIT kit. Is that something you're aware of, Bruce? Or Adele?
Adele, are you?
I don't think there's a reminder that they haven't returned it, but I think it will show up that they've received it, but that they just haven't. Like, I don't know that comes through to the GP. Like, we're able to access it on our end, and we do our follow-up from our side. But I don't think GPs have access to that particular part.
There are different dashboards. Some of them, the ProCare one's pretty good, but some of the other ones are a bit aren't as good. Turmeric capsules are promoted by pharmaceuticals. Are they protective against CRC?
I haven't seen any evidence for that, but what about you, Ian?
No. But
well, they're supposed to make you feel fully energetic. I did try them one day, and it didn't seem to make any difference. So, N of one, I think it's probably a marketing con, but
unfortunately, don't believe everything that you see on the packet.
Absolutely. Okay, so have you got any? So we've got about another 5 minutes. Is there anything that's jumping out at you there? I think we've covered most of the care things.
Perhaps I could talk a little bit about where we are with using FIT tests on symptomatic patients. There's been several large studies, mostly in the UK, looking at patients who present with symptoms that could be bowel cancer. So PR bleeding, iron deficiency anemia, change of bowel habit, and they are the sorts of people that we scratch our heads and say, should we do a colonoscopy on this person? What they have showed is that using the same FIT test that we use, but setting the threshold much lower, you can find the vast majority, or you can identify the vast majority of the people with cancer. In fact, at the lowest or the highest sensitivity, the lowest threshold, up to 97% of the cancers can be identified using this test. And it also gives you, it removes about 60% of the patients who have a negative test. From the likelihood of someone with a negative test who has symptoms having a bowel cancer is extremely low, like less than 1 in 300 or 400, despite the fact that they've got something. Now, they've got something, but it may not be a bowel cancer. So we at present are doing a pilot study in Waikato, and we've just started in North Shore, looking at patients who are symptomatic on the waiting list, waiting to have a colonoscopy. And what we are doing is the patients who have a very high result are going forward to having an urgent colonoscopy. And so far, half of those patients have a cancer. So we're identifying a huge number of the cancers from a big population with this test. Our hope is that maybe by the end of this year or the beginning of next year, we'll be making it available to all the DHBs as a screening test for symptomatic patients. And in the long term, it will be in the hands of GPs to use within specific symptom patterns that they can actually use, and then identify patients where they should follow, but they don't. The chance of them having a cancer is very low. The important thing for us is working out what is the best way of safety netting those patients who we don't colonoscope, so that the patients who we have a cancer that we haven't identified don't fall through the gaps, and so that we identify them relatively soon. They don't just disappear into the ether.
Mm.
So that's quite exciting, I think.
Yeah, well, that I mean, you know, because it is that and things like ovarian cancer, the terror of primary care, basically. Going back to the bloating issue. There's a couple of comments about dashboard. Some say they on the dashboard it does show they have been sent a kit and not done it. So great, we can reorder one as most have lost it. And somebody else saying they can see. So I have trouble with my dashboard, but that's I think something to do with my machine. So any other comments? Any final take home? Harbour PHO, somebody was saying they said the dashboard was using so. So any final wrap up comments from Adele? What parting message do you want us to go home and sleep on tonight?
I'd say encourage people to do the FIT test. So encourage people to participate in the bowel screening program, and just be aware of bowel cancer at any age.
Well, that's good to know. Ian?
I would particularly encourage you to talk with your Pacific and Maori patients about the importance of bowel screening, because that group of people have the lowest participation, and they are the hardest for us to reach with the screening program. And you might be surprised, but patients really take notice of their GPs if their GPs are saying this is actually saving lives and this is finding cancers early. So I would encourage you to try and particularly for Pacific patients, because they're the least participators in it, and patients with continuing symptoms, make sure that they do get a diagnosis. And so, even if they're young and if they've got bleeding, continue to search for a diagnosis.
I've taken with patients with things like smoking to beg them to get them done. So maybe we could suggest to our colleagues, well, I think when you beg a patient to do something, it shows you've got some concern and skin in the game almost. And I've had some remarkable successes. So looking at this as a new way of intervening with people. This is really important. I'm begging you to do it. So
okay,
it just has a different ring to it, I think, than this is important. You should do it. It sounds
that's right.
Like the headmaster talking to you. This sort of sounds like yeah. Well, thank you very much. That was a great session. And Adele, you go down as the most enthusiastic gastroenterologist I've ever met. So yeah. And Ian, it's
thanks for the award.
all those years that you've got, all that experience is fabulous to have you on the broadcast tonight. So thank you very much for your support, and we'll say good night to everybody.